So you can argue there's really not enough numbers in here to really detect circulatory deaths. But no increased mortality. This is again from the Nurses' Health Study. And since I'm not in Harvard, I can express some concern about the Nurses' Health Study, and a lot of their findings have not been validated in prospective trials. For instance, every benefit to a vitamin or nutrient supplementation has never been validated in a prospective trial. The other problem in the Nurses' Health Study, look at hormone replacement therapy. It was tremendously beneficial to the nurses in the Women's Health Study, but of course when we did the WHI, we found out it was overall harmful with increased mortality. So there's a certain selection bias to this study that I think we have to acknowledge before we place too much emphasis on their data. So they went in and they took a look at just on self-report of menses. Now, unfortunately, they did not have any, from their questionnaires or from their serum, they did not have the ability to identify women who had irregular menses due to hyperandrogenism, or women that had irregular menses to other reasons. And certainly, one of the things you have to consider in nurses, highly educated, competitive women, is the hypothalamic amenorrhea, so a hypoestrogenic cause to their irregular periods. And that's certainly one of the critiques of the study, is that perhaps the fact that they found, as I'm going to show you, that irregular menses was a marker for cardiovascular events, that we don't know that this was necessarily due to polycystic ovary syndrome as opposed to hypothalamic amenorrhea and hypoestrogenic conditions. So enormous amount of data in terms of people years. And I think, again, why this is an important study, and don't leave here thinking that I don't think this hasn't influenced the way we think about polycystic ovary syndrome, because what we found in this study is what we look for with any sort of intervention or association. Is there dose-response association between menses and cardiovascular events? And yes, there was, and it became statistically significant at the irregular and very irregular compared to very regular and regular. You can see the stepwise increase. Similarly, they looked at the known risk factors they had for cardiovascular disease, and what they did see is they saw a stepwise increase in diabetes, in hypercholesterolemia, and in hypertension as you increase menstrual frequency, again, implying a dose-response relationship between the degree of oligomenorrhea and history of coronary heart disease. Now, we've unfortunately seen a proliferation of similar studies in existing databases. So the Rancho Bernardo study, and the Rancho Bernardo is a planned community north of San Diego and one of the most beautiful spots in the U.S. And people also criticize the Rancho Bernardo study as it's not really representative of the U.S. population, world population. And they went in and they looked at PCOS in this postmenopausal female population and found a significant association between PCOS and cardiovascular disease. So you look at it and you say, okay, there's another nail in the coffin. And then you look, how did they diagnose PCOS? Well, I guess they felt that we didn't have enough criteria out there already. So this is now the Rancho Bernardo postmenopausal PCOS criteria. They added a history of personal infertility, inability to carry pregnancies, central obesity defined as waist circumference greater than 88 centimeters, insulin resistance, or fasting plasma glucose greater than. So, I mean, why not just add in there every other cardiovascular risk factor and call it PCOS? So what they did is they expanded the criteria for PCOS to meet the profile of patients likely to develop cardiovascular disease, i.e. they stacked the deck in their favor. And if you take a look at their association, the two most common abnormalities, which are not part of any premenopausal diagnostic criteria for PCOS, are central obesity and biochemical insulin resistance. So again, I think the events are expected when you stack the deck like that. And indeed, they found that these women had higher mortality, quote unquote, than the women without PCOS. This is another study, the Women Ischemia Syndrome Evaluation. They took a look at postmenopausal women, and they, again, tried to post hoc assign a PCOS phenotype to these postmenopausal women. Now, again, you can see that if you had PCOS, you were more likely to die in this in this cohort. But how did they diagnose PCOS? Well, they did like we did, and they took a look at history of irregular menses, and they also measured testosterone. Now, many of you don't spend your life arguing about testosterone and how to measure it, which I seem to spend a lot of my time doing. But I can tell you that this is measured by tandem mass spec. The cutoff of testosterone greater than 30 nanograms per deciliter, unfortunately, not even mass spec can determine if you're below that or above that. We have a paper that it's just been EPUB'd in JCM, and this is an interesting study in which we took 626 samples from a study of women with PCOS that we had done a couple years ago. And we randomly labeled them, and we spiked them with 10%, also randomly labeled. And we anonymously contacted 3 labs. We contacted Quest, which is a commercial lab in the U.S. that runs all their testosterones by mass spec. We contracted with the Mayo Clinic, which is a research grade that does mass spec. And then we ran a research RIA assay through the University of Virginia. It's sponsored by a core lab sponsored by the NIH, and we told none of these labs what we were doing. One of the things when you look at when they validate assays is almost every one of these studies has been supported by a assay company, okay? Number one. And number two, all the results are always presented anonymously, like lab A, lab B, lab C, lab D. Number three, everyone knows on that day that, hey, we're doing the interassay correlation, so let's send the A team up.